Welcome to today's CURiE Conversations. I'm Jessica Schuster, the editor-in-chief of CURiE, and we are looking forward to highlighting one of our recent articles, which reviews oligometastatic disease through the ACRO pathway. And we have our palliative editor, Ginny Lee, that will be interviewing and discussing the ACRO pathway with Chris Jahraus. And we look forward to having many more CURiE conversations with our authors, and also being able to highlight upcoming ACRO pathway publications. I know I personally have appreciated this specific article because it kind of helps to provide some insight into the areas that so many of us face clinically that are a little more gray and not really laid out in other guidelines. So, Dr. Lee, if you could give us a brief introduction and then we'll get started.
Hi there, I'm Dr. Lee. I work with Texas Oncology. I'm a medical director for the San Antonio region for Texas Oncology. And as was stated, I'm also the lead for the palliative section for the CURiE publication. So if there is anything palliative that you all have to send over to us, that would be great. I think it's a really important field for us. It's something that makes up a good majority of our practice. And as we're seeing now with all of these immunotherapies and targeted therapies, it's something that's more frequently coming up in our discussions. And so leading to this great article and pathway and kind of direction of how we can do this. So this article is really helpful for all practicing physicians, because everyone's going to run into oligometastatic disease. And I think it's a great area for us to promote the use of radiation in addition to all of the systemic therapies for these metastatic patients. So without further ado, I will introduce our lead author on this paper, which is Dr. Jahraus, and he can correct my pronunciation if wrong. He recently changed how he's pronouncing his name to go back to his German roots. So some of you may know him as he is on one of the ballots for positions in ACRO in leadership. But for those of you who don't know him, he will introduce himself, tell us a little bit about his background, his career path, how we found radiation oncology, and what led him to writing this paper.
So, well, thank you so much. So, yeah, it's kind of an odd thing, like we said, to change your pronunciation of your name after 50 plus years of life. But yeah, I've gone back to, or my family and I have gone back to saying Jahraus. So I'm Chris Jahraus. I'm a board certified radiation oncologist in Alabaster, Alabama. I own my freestanding solo practice, Generations Radiotherapy, and I have been very enthused and blessed to work with just remarkable people at ACRO, and today most particularly the oligomets team. And I have to say, first off, that I really don't get much credit for this. I was just the guy who said, "Hey, let's write this, and if you want me to, I will." And somebody said, "Yeah, write it." But the real credit goes to the team, which is led by Bridget Kuntz, and just a remarkable leader. Really devoted to providing really good information. And, you know, this is one of the first of several pathways that we intend to release. And this is just the manuscript version of it. Hopefully around the time of the meeting, there may be more information coming out about ACROPath and some of the directions that we hope that will head. But for now, we have this manuscript that is a comprehensive, as comprehensive as a manuscript can be, at least, a guideline to managing oligometastatic disease. And what makes this so exciting is that it is really, to my knowledge, the first official guideline or pathway, a clinical pathway, obviously, type paper in this setting. So it's That's really a neat thing for ACRO to be leading the pack in that way.
Yeah, and I agree. I think there's a lot of information and publications and guidelines for metastatic disease, but they tend to be more broad strokes and tend to have less of a direction to give to us and more of, oh, you can do this or that, without really kind of giving some firm guidelines, which is really helpful because these situations can be so tricky. So
Yeah,
why don't we start with oh, sorry, go ahead.
no, yeah, I was just going to say it's kind of like when you were in residency, there was the textbook that was encyclopedic and that gave you this, that, and the other. And the other guidelines that are out there have a little tendency toward doing that. But this is the equivalent of that textbook, like when you're in residency that just said, do it this way. This doesn't say do it this way completely, but it certainly gives you clear guidance on how to do it the way that the team regards as optimal.
Yeah, I agree. And, it's excellent for those coming out of residency in early years of training where you're not sure, or even those who are more advanced in our training, just to have, because the field's changing all the time. And so even if it's not a direction of, oh, you should do this, it's more of a thought process. And it's
Yeah,
great to have those options.
exactly. And even in my own practice, for instance, I do a lot of SABR or SBRT, whichever you prefer to call it. But I don't do a lot of adrenal SABR. And so I had an adrenal case. And so what did I do? I picked up the paper and went back and made sure that my approach was meeting all of those standards. Again, even though I wrote it, I was just the compiler. And you've got to look at every person on the manuscript. They all get credit. And we've got just some incredible names on there. And if I tried to list them all, I would forget one. So I'll just direct you to the paper.
Yes. And so for those of you to find the paper, you can go to the Cureus website, which is our ACRO journal website, and you can find it there. Or if you just Google ACROPath Oligometastatic Disease, it'll pop right up. And you can see all the great people who've helped to write this and have it there for you.
And
So
there's also a link on acro.org. If you go to our homepage, I think it's the second banner click or something like that you can click on it. It'll take you to CURiE, and you can access it there too.
So why don't we start talking about this first with a brief definition of oligometastatic disease, because it's a confusing term because studies that have looked at these populations use different definitions, especially prostate. Sometimes it can be numerous metastatic. Oligometastatic for most people tends to think of one, but it can be numerous. So what definition did you use and how did you decide to use that definition for this paper?
So the group defined oligometastatic disease as generally being 5 or fewer metastases, and that I found was a really helpful thing because, for instance, in dealing with one of the ROBMs, they said, "Well, we consider 3 or fewer oligometastatic." Well, I said, "Well, if you look at ACROPath, this thing that was just published, they say 5." So that's a prime example that I have already used where this has helped defend my approach to treating the patients. And I think the basis of that, if I'm not mistaken, was the Wexelbaum definition. And there it was Wexelbaum and another person, and I'm forgetting the other author's name. But in any case, everything in these is based on good, solid data right out of primary literature. So that everything in here is based on, very, very little, if any, is based on, we think or we feel, that sort of thing. Almost all of it is, primary data, the clear evidence-based approach.
So speaking of all that data, I know that there is so much out there on metastatic disease, oligometastatic disease, for all the different sites and all the different disease types. How did you parse through it all and, creating pathways for this when there's so many conflicting evidence or different studies that look at different things? It can be really difficult. So what was your process and your methodology of deciding which literature to use and how to formulate a guideline from that?
That's a great question, and that really sort of gets to the methodology of our Pathways ACROPath project in general. And what we generally do, whether it's oligometastases in this case, or breast or prostate or lung or head and neck or whatever, any of the others that are still coming out, um, what we do is we assemble a team. And each member in that team decides, okay, this is my particular area of interest. So, Bridget, the lead for oligometastases, kind of took broad oversight. And I hope I'm not misstating this, but I think Bridget was the one who kind of addressed some of these questions of defining oligometastatic disease and that sort of thing, and then came back to the whole group with their recommendations, and then the group as a whole voted on those. One of the really beautiful examples of this comes from Dwight Herron, the current president of ACRO. He handled the CNS metastases section and created this really great couple of graphics that are in the paper that show a gold, silver, bronze strategy for managing brain metastases. And it's really useful. And it is really that kind of thing that a resident studying for boards, or somebody who maybe doesn't do a lot of brain mets or whatever, and now they're in the role of, okay, what am I going to do, can just pull out those two graphics and really get in just a few seconds a clear answer of what is the optimal, the gold, what is acceptable, the silver, and what is acceptable in certain situations, the bronze pathway. And so all of the recommendations in here are based on that gold, silver, bronze strategy, where again, gold is the gold standard. That which should, almost always be appropriate, barring certain, conditions or what have you. Silver is a perfectly acceptable approach, but maybe it's not as ideal on some level. Maybe it's more costly, that sort of thing. So that's an appropriate approach. Bronze, again, are those that are in the sort of uh, select situations. You don't want to use them for everybody, but they're appropriate when there's good reasoning behind it. And that's kind of how we define the entire ACROPath process. It goes for this gold, silver, bronze sort of Olympic medal approach to things, and that just speaks to its accessibility. NCCN is clearly a remarkable resource, something that we aspire to be like in some ways, in terms of its acceptance and its validity. But NCCN gives you everything in these very sort of clear scientific terms. This is level one evidence or whatnot, and this is the approach and the feel of ACROPath is intended to be a little bit more everyday doc on the street. So again, it's that kind of reference that, okay, what should I really do here? And is this way that I've always done things really the right way, or have we moved beyond that? In the case of oligometastatic brain disease, when should we use FSRT or SRS? Versus when should we be looking more at whole brain, and those sort of things. So again, that graphic that Dr. Herron came up with for his section, that was all put through the oligomets team. They looked at it and had a chance to say, yes, I think this is reasonable. No, I don't think this is reasonable. Based on this data, we need to consider X, Y, or Z, or so it's a very collaborative, very uh, mutually respectful process where each expert on that panel is an expert in their area, but every other expert is looking at it in terms of, how does this apply to me? And you have some very real world experience in there, like you've got not just very lofty, well-respected academics. You've got everyday radiation oncologists like me, solo practice, single linac, and it's written in a way that it's accessible to that.
Yeah, and I think it's great for that. And I think, sometimes too, we all come out of training, we're all a product of our training and
Oh
who
yeah.
the specific attending was that taught us that disease site. And things change, and sometimes it's good to reevaluate and look at
Yeah.
that and just to see how everyone else is practicing.
Exactly. And so, I trained at the University of Kentucky under Roy Patchell and Bill Regine and Mo Mahoodan. And, these are all people who defined the need for whole brain radiotherapy. And so believe me, when people started talking about SRS alone, I was going, oh my gosh, that's almost like sin, I mean, and in fact, I think I called up Bill Regine at one point when it was first coming out, and we had a discussion about, okay, is this right? Isn't it right? Now we have a panel of experts. Unfortunately, Bill is too busy. We didn't get him to join this, but we have other experts that are, you know, really, really valuable in terms of giving you that broad perspective. So it's not just, I now have the perspective not just of coming from UK, but I have people at all kinds of different centers. Bridget was at Duke, now she's at Advent. Dwight was at UPMC, now he's leading a private group. So you have this really nice breadth of experience that really speaks to the remarkable value that the pathways bring.
Yeah, it's a wonderful kind of well-rounded view. So
Yeah.
if you don't mind, why don't we delve into kind of each site a little bit, and you can kind of give us a bit more background. So you mentioned the brain metastasis, which I really like because it does kind of stratify when we should use SRS or SRT versus whole brain, and even when things progress. So if you could speak a little bit more to kind of that pathway in particular, and kind of what thought was used in there as far as like prioritizing SRS over whole brain.
So, with all of these approaches, number one, the patient well-being is, and this is, it's funny, I sound like a stuck record here, but this really does speak to the strategy of ACROPath overall. The first priority is always what's best for the patient. What is the evidence-based strategy, highly defensible, highly, standard of care, mainstream, if you will, that gets
Mm-hmm.
the gold recommendation. And so, what's the best thing for the patient? And then, beyond that, then we talk about, okay, what is the best thing for the patient from a holistic standpoint? Is SRS better in a brain metastasis patient in some situations? You know, um, is whole brain better in other situations? And then finally, if everything else is equal, then in terms of creating those differentiations between gold, silver, and bronze, you have the cost factor. And, is this economically a feasible approach? But far and away, the top is the patient well-being. And so in brain metastases, if you go in there, and I don't want to give away everything in the paper. I want people to go to the paper and read it because it is such a valuable resource. But you'll see that SRS in limited number of metastases is highly appropriate, especially in patients with malignancies other than small cell. Whereas when you get into the small cell patients, then there's a little greater prioritization on whole brain but there's always again, I love that graphic that Dwight created, which is, not to say that there aren't other good graphics. There are a ton of great ones in there, but that one that Dwight created is just such a neat little bingo sheet almost that you can say, okay, this on this on this, that's what I do, it's pretty cool.
Yeah, and for those of you, you can't see it right now, but when you look at the paper, you'll see, and it strategizes it basically if the patient has had whole brain before, no prior
Exactly.
whole brain, if they've had whole brain or SRS and they're progressing, and so it really does give that guideline, as well as I think the question for a lot of people is like, how many are too many for SRS, and when is it too much? And so I love that you've kind of placed that in there too as a upper limit, essentially, of like 10. And that's not to say that
Yep,
you can't do it
exactly.
again. greater than 10, you can still technically do that on there. It's just not as high of a rating. And so it kind of
Exactly.
strategizes it.
Exactly. And that particular question was one of the issues that came up in discussion of, what is that proper number? And, there was a bit of back and forth. And I think, everybody kind of landed on 10 as being, this is the thing, there's data for almost everything, it seems like nowadays. So, but now what does this group of experts really regard as the most reasonable? So again, that's just a great example.
Yeah, and to go back to what you were saying too, it is a different scenario with small cell patients. And I love that there's a separate graphic and pathway specifically for that, because that's an ever-changing field too. I know when we were, in training, essentially it was always, PCI, and now we're seeing more SRS in use for small cell, for solitary brain mets, and,
Well, and
or patients declining PCI, and we're monitoring, and so we're catching them at different times. So having that pathway is really helpful for kind of the involvement of the field.
absolutely. And the other thing that is so unique about this oligomets pathway is that we looked at it from two standpoints. The first being what is the site of the metastasis, and the second is what is the origin of disease. And so the first half of the paper focuses a bit more on the site of metastasis, and the second half talks about unique situations, related to the origin of the disease. And that's a really honestly, when we attacked oligometastases and talked about this, when Bridget and I first sat down and said, okay, how are we going to go at this and everything, that was a big deal. That you would have this sort of back and forth of, okay, we have metastases in the lung, but what's the primary? We have metastases in the brain, but what's the primary? And so I think, you know, again, I'm not blowing my own horn by any stretch of the imagination. I just compiled this thing into a written form. The work was done by these authors, and I think if I may, I'm just going to take just a second to list them all. Paul Wallner is my co-chair of the ACROPath program. Members were of the oligomets team were Dwight Heron, William Crook, Stephen Finkelstein, Alexander Harris, Larry Keston, Evan Landau, Doug Rivera, Tarita Thomas, and of course the leader of the group was Bridget Kuntz. So really, again, I just I'm the guy who my dad was a newspaper editor, so I put it into journalistic style, but they're the ones who did the work, and they're the ones who are to be thanked for this.
My dad was also a newspaper editor, so I can
Awesome, we have something in
appreciate
common.
that, and also the amount of work that you put into to compile all of this, because it is difficult to make it concise and readable and understandable to everybody. And so
Yeah.
it really was a good job in all parts.
Thank you. The other thing, as I'm just sitting here, I have it pulled up on my screen next to me. The other thing that's really kind of neat about this is that we go into a whole separate section on, motion management, for instance, and we've got a nice table in there, table one, that talks about, what's the ideal motion management, what's silver, what's bronze, and then we go into all other sorts of very granular aspects of doing this. What should you contour on? You should, in this situation or that situation, you should have, this is regarding lung metastases specifically. You should do it on a 4D ideally. Here's the compromise, here's the minimum. Even down to dosing guidelines. So this is not something that just gives you big lofty ideas. This gives you real world how to do it. How to take it from, okay, I've got two lung metastases, one is here, one is here, how am I going to deal with that? And it gives you real world guidance.
Yeah, and I think that's what or what I've really appreciated about this paper. Like you said, for the motion management, where do you contour? And these are discussions that we've had in the workplace with our physics team of, do we contour on the average or on the free breathing? And how do we use this? And we hadn't found good papers prior to this on what we should do. And so having that is really good, just practice. And some evidence-based strategies for us to plan and triage our patients and treat appropriately.
Yeah, and I think, it's a real coup for ACRO, this relatively smaller society and certainly just radiation oncology specific, to really come up with this powerful a document and this powerful a manuscript just to guide people. Again, I'm looking at table 2 as we're talking about this, and table 2 gives you really good definitions of what your constraints ought to be, so that if you have a 3 fraction plan, follow these constraints. If you have a 4, follow these. If you have a 5, follow these. It's this kind of really it's the kind of paper that you want to pin on your bulletin board, so you can pull it off and sorry, I guess I'm dating myself, or put on your desktop on your computer and pull it out regularly as you're looking at treatment plans.
Yeah, for sure. The other thing, as you mentioned, it is really nice having it designated not only by site, but by histology. So from the start of, SBRT coming out with like the Saber Comet papers,
Yeah.
they always did stratify a bit on, well, this works well for lung patients, but not so much for breast and so forth. And so taking that into consideration is really helpful. You can see it a lot in the bone met section that you all put together. There is a specific, stratification based on the site and also the histology of it, which is really helpful depending on what you're seeing and allowing you to target the dosing differently or, do conventional fractionation versus SRS. And so kind of, why don't you talk a little bit more about the bone met section of it, since that's something that everyone sees all the time in their practice, and kind of maybe some highlights of that section for us.
Absolutely, absolutely. So in bone mets, we have non-spine and vertebral body mets separated out, very very clearly defined. Again, we go into all of the recommendations. And I know this is not necessarily bone met specific, but one thing that's great about this paper is that because it's a clinical pathway, and a very well documented clinical pathway at that, this is the kind of thing where if you have this paper and you're getting pushback from an ROBM, you can say, have you seen ACROPath Oligomets? And if not, let me send it to you. And, and there it is. I mean, it's defensible. It defends your approach, and but yeah, getting into bone mets, there are some particulars in terms of dose, where higher doses are tended to be associated with a little bit better local control, and goes into specifics of vertebral body treatment, which of course is a little different than what we would do, say, for a lung mat. And one of the things I'm just going to allude to where I really, really want this to go in its next iteration, because this is the thing about these pathways, is that they're dynamic. These are living, breathing documents that are being reviewed every ballpark 6 months or so, certainly 6 to 12 months. And they will be updated. And so in iteration 2 of oligometastases, what I'm going to charge the group with, if I can get away with it at least, is giving us some guidance on, okay, what about previously treated sites? You know, and how there's data out there that says that you can retreat in certain approaches. And how does that change your dosimetric limitations? How does that change your fractionation? All of that sort of thing. And so, you know, I think this is going to continue to evolve. Again, NCCN guidelines are kind of the gold standard of guidelines. This is not a guideline per se as much as it is a clinical pathway. But that said, we're aspiring to do something similar, but yet much more granular in radiation oncology, but similar in the sense to NCCN in that it is living and changing and being updated continuously. And so that's a critically important part of ACROPath. And in the coming months, I think there'll be some more information coming out about other ways in which we will make ACROPath available. And there's some things that I can't yet. Here's a teaser. I can't yet talk about, but in the months ahead, that we will absolutely be talking about more in terms of making this available beyond just a manuscript or a series of manuscripts, even.
And I think that's, kind of a key point, is it being dynamic, as we've stated throughout this whole thing. Things have changed since we all came out of training, and
Yep.
they're continuing to change. And think
And
as
this is
patients
how you
live
stay
longer.
up. Yeah, this
Yeah,
is how you stay up to date. Obviously, it'd be great if all of us could read, every article that comes out in the Red Journal and JCO and New England Journal and everything else. It doesn't happen. We all have our areas of interest, but this is the kind of thing where it distills a lot of that down into a bite-sized sort of document.
yeah. And I love how you say that you're going to update it, because, things change, and also our patients are living longer with all these targeted therapies. So retreatment is a very real thing. And I think it's something most of us don't feel very confident in,
No.
because it's never been, because we've never had a document or a pathway or a clinical guideline that says this is how you discount the time for healing. This is how you reevaluate this. It's all been very kind of hand wavy and kind of like
Yeah,
person
well,
dependent.
I do
Yeah.
this or I do that or whatever, and well, my mentor said to do it this way, uh, um, you know, I have two patients that I'm just treatment planning right now who both have lung disease or lung cancers that have recurred, probably a new primary 10 years after they were, originally treated. And so, okay, 10 years, that's a really nice, comfortable big window. And, so I'm a little more comfortable with what I'm doing, but I sure as heck have to be really, really careful too. It would just be really nice, and again, that's going to be my charge to the Oligomets group. Not that I get to be too bossy with anybody, but my encouragement to them is going to be that for the next iteration that we look at, what are recurrent strategies and retreatment strategies, and is there because there is in the literature, there are some guidelines, from head and neck cancer, from spine, whatever. Maybe we can include that in a forthcoming pathway. So I think this is going to continue to be an exciting thing for years to come. That certainly is my goal.
Well, we appreciate it, and we will certainly welcome any guidance you have on retreatment, or what the group
The
consensus
guidance
comes to.
they have on
Yes,
retreatment, believe me,
the group, yes.
it'll be the experts, not me.
Um, so let's go through a few other sections here. So
Okay.
you mentioned before the adrenal metastasis, which is interesting. We've all heard of it. Not all of us have treated them before. And so again, this is something that really takes into the motion management, the target delineation, and so forth. So and dosing, which I think has always been kind of vague and variable. So
Yeah.
can you speak a bit more to that?
Exactly. I mean, you're in an area where you've got a bunch of bowel and you've got, obviously kidneys and maybe liver, depending on which side. So again, there's a really great table, and this is kind of a hallmark of ACROPath, is that I love tables. And when I was in residency, I would make these cards that distilled down tables of things, and gal, and I'd have them in my pocket. Again, I'm dating myself here because now we would all do it on our iPhones or whatever. But nonetheless, the data is there. And so table 4, for instance, is the treatment algorithm for approaching adrenal gland metastases. If the size is less than 5 centimeters, and you can meet the 5 fraction GI constraints, here's the gold, silver, bronze approach. If it's greater than 5 centimeters, then what do you do? And then maybe there are cases where you can't use SBRT or SABR. It's funny, my co-chair, Paul Wallner, of the project hates the term SB or SABR. And so every time I say it, I feel a little twinge of guilt that Paul is, listening to this maybe and thinking, you know better. But anyway, I call it SABR because it's just prettier, But anyway,
It sounds way more intense and kind of aggressive. It has that
yeah.
nice ring to it that makes you sound like you're really attacking something.
Yeah, exactly. I was at an ACRO refresher course, and there was a gentleman out of Canada, and I'm blanking on his name. People probably know who I'm thinking of. And he, as he started his presentation, the lights dimmed down, and Star Wars music came on, and his slide said "Saber Wars." So that sold me on that. But anyway, back to the adrenal gland metastases. It gets down to motion management. How do you define the target? What dose should you use if it's less than 5 centimeters, and if you can meet all the constraints, what dose should you use if it's greater than 5? In other words, what's a reasonable compromise? And that's the question that we all deal with when we're looking at these plans. What's a reasonable compromise?
And I think it's great for that. I also love, I just want to highlight this one section where it says for optimal simulation, administer oral contrast 15 to 30 minutes prior for best visualization, because that's a question, sometimes we're asked by the CT tech of when do you want to give the contrast? And we're all kind of, I don't really know, like what is the best time to give it for this person, for this site, for this. And so those like little tricks on how to simulate properly really can make a huge difference for us.
Well, and if you're fresh out of residency, maybe at your program, they just always knew to do it a certain
Yeah.
way. And so it never came up. And I mean, let's face it, timing of contrast is not exactly a board question, So, what is the right way? I mean, it addresses things on a very granular level. And I find that to be very useful.
Yes, exactly. And just very practical for us all
Yeah.
to incorporate and have this. So when you are asked, you have a reference to look at on the best way to simulate these patients and get them so that you have the best CT for your planning.
Yeah. And so ultimately, if you're following ACROPath, you're going to be guided down a very logical road that is based on absolute solid science, evaluated by some of the best experts in the field.
And I think these are helpful, and the coming pathways will be excellent too. Like you said, for graduating residents, new residents, or anyone who just switches a job or
Yeah.
has new techs that come on. And,
Yeah.
things are often, as you mentioned, in a particular facility can become standard. And then, and that's just how things were done, but they may not be the best way. And so it's good to take a look at that and reevaluate and make sure that you are doing it optimally. And
Exactly.
if not, you can upgrade.
And in my first job, for instance, I did peds and GI, and that's all I did. And so when I left that place and went on to be a more general radiation oncologist, oh my gosh, all this stuff that I hadn't done for, many, many months, years, whatever, you know, uh, I had these questions in my mind. I could tell you how to treat a Wilms tumor or a medulloblastoma like nobody's business, but you don't exactly see a lot of those in private practice, So it's that exactly as you said, it's that kind of reference that can be used by somebody who's maybe recently changing jobs or changing area of specialization or what have you.
Now, next section I want to look at, which is really exciting, is the lymph node metastasis, because I think it's something we've been seeing more of, at least I have in my practice, is, general radiation oncology, where someone has a solitary lymph node metastasis. But again, there hasn't been great kind of guidance or direction in what to do, what dose to use. And so let's talk about that section a little bit.
Sure, and help me out. What page is that on? I'm scrolling through my things so that I can at least use it as
It's
a
right
guide.
under the adrenal metastasis section.
Okay, super. Yeah. Clearly I don't have it memorized, but in any case,
Nor should you. That's why the reference is here for us all to go and look at.
yeah,
And after oral boards, nobody needs to memorize anything.
yeah, exactly. So hang on, I'm getting there. I'm getting there. Give me a second. Uh, what specifically? Feel free to kind of. There we are. Okay, I'm
Sure.
getting
Yeah.
there.
So
Thank
like
you.
about dosing, about how did you guys come up with this? Because it can be tricky based on site. And so as far
Yeah,
as like regimens and things like that?
absolutely, absolutely. So, here is where we really depended on the people that actually do this stuff, because I certainly don't do a lot of lymph node metastatic, oligometastatic cases, and it gets into the strategy because, depending on where it is exactly, you're going to have some really tricky situations, much as in the case of an adrenal where you're sitting around a lot of small bowel, here you're up against some potentially very sensitive structures depending on exactly where we're treating. And so, again, everything is based on literature. And so if you notice in there, you have the primary sources referenced there, that they pulled this from. In terms of, I will confess to you that in terms of the development elements of this, I was less involved on this particular section, but and more involved in just kind of pulling it all together at the end. But I think that especially in cases like prostate cancer, one of the examples that's given here, these are really pertinent questions. And these are things that they give you some really solid answers on.
Yeah, and I think just to highlight some things in that section, there are dosing, there's again setup and respiratory management guidance. There's also guidance based on the site. So for mediastinal tumors, what is appropriate for pelvic tumors, some dosing for SBRT versus more conventional or hypofractionated regimens, even in
Exactly.
SIB dosing, which is really nice to have some general fluid guidelines for something that you
Yeah.
might not treat all the time.
Yeah, exactly. And SIB is a great example. That's actually the last sentence of that section. And that's one of those where for those of us who have been treating a little bit longer, which SIB regimen is just right. And, whenever I'm doing an SIB that's something, other than head and neck or what have you, I'm always getting out the calculator and figuring out the EQD2s and stuff like that. And, here you have a really solid starting point for that.
Yeah, and I think all of this is a really good starting point. And then obviously, every patient is a little bit different, and you may need to stratify it or change things a little bit, but at least you have a good place to start.
And in each case, you have the reference for the studies that it was based on. So, you're not just plugging into PubMed, oligometastatic lymph node, or SBRT lymph node or whatever. You have the references that are regarded by the team as being the most appropriate.
Now, is there anything else that you'd like to highlight? Anything we haven't chatted about yet that
No,
was great about
Jennifer,
this
I think you've done a great job. You've clearly read the paper. Thank you for that. But you have done a great job of highlighting all of the critical parts here. I'm realizing I probably should have had Bridget on here with me as the senior author, and she could comment on more of this perhaps. But again, big credit to her for really organizing and assembling this team, and to really, again, all the credit goes to these authors. I just put it in the format and brought the team vision to it. But the people that wrote this, again, I'm going to say their names one more time. Paul Wallner, Dwight Heron, William Crook, Stephen Finkelstein, Alexander Harris, Larry Keston, Evan Landau, Doug Rivera, Tarita Thomas, and Bridget Kuntz. They're remarkable people, and I think the college owes them a great amount of gratitude for what they've done here.
Yes, we all certainly do, and for the upcoming pathways as well. Now, if
Yes,
someone wants to get involved in helping with these pathways, is there a way that they can do that?
absolutely. They can email me at cj@genxrt.com, genxrt.com, and my initials. And I am more than happy to plug them in. We've got some really exciting things coming in head and neck, in lung. I think we could probably use a few more people in GI. And rectal, and also we really need people to step up and volunteer in neuro. So for those things in particular, would really love to see some things And with that, I think you've got everything out of me that you can on this.
Yes. And so thank you for all of that. Come find us all at ACRO. We will all be there. We'll happily discuss these papers or otherwise, or future directions and things like that, future podcast directions and what have you. And this was a great conversation. Looking forward to the next couple of pathways.
Thanks so much, Jennifer, and thanks, Jessica, for featuring this.
You're very welcome. We hope to have more CURiE conversations going forward, and I think highlighting the work that is really supporting us out in the field, doing the work, day to day, and trying to help us, kind of process the fire hose that is new papers and new things, and having someone kind of compile things so you can feel like, okay, where are the boundaries of my knowledge, and where do we feel like, okay, I don't want to be a dinosaur, but I also
Yeah,
don't want to be the very first person to do something.
exactly.
So thank you so much for both of your time, and we'll look forward to the next one.
Thank you.